Right. All right, good evening, everyone, on election day. Hope you guys already voted and are now ready to relax a little bit and just talk about updates on the management of pancreatic cancer. We're very fortunate to have our moderator and distinguished um, uh, member of MOASC and Dr. Andrew Hendifar, who is a professor over at Cedars-Sinai and focuses his care in pancreatic cancers and other GI malignancies, as well as his colleague at Cedars, Dr. Arsen Osipov, and from UC San Diego, we have Dr. Andrew Lowey. So thank you very much for joining. And Dr. Hendifar, I'll let you take over the baton from here and forward to a lively discussion. Just a couple of housekeeping uh, items. We should have time to open up this forum for people to participate. If there are any questions while the panel is talking, please feel free to write your question or comment in the chat portion. We'll get to it and address it at the appropriate time. All right, Dr. Hendifar.
Yeah, thank you. Thank you, Dr. Lashkari. Thank you for the introduction and going over the housekeeping rules. Um, Most of us on this call know Dr. Lowey. He's a professor of surgery. He's chief division of surgical oncology, and he's the associate clinical director for the MOASC Cancer Center in San Diego. And Dr. Arsen Osipov is an assistant professor of medicine. He's also the director for the Pancreas Cancer Multidisciplinary Clinic and the Precision Medicine Program at Cedars-Sinai Medical Center. So there's our two fine panelists. Today's presentation will go through operable pancreas cancer first with Dr. Lowey, and then Dr. Osipov will talk about novel systemic approaches and delivery of pancreas cancer care. And if there's time, there's no promises that there will be. I'll talk a little bit about supportive care and some of the new medications being developed for pancreas cancer cachexia. This here. All right, here we go. Dr. Lowey, I'll hand it over to you.
Okay, great. Thank you for the invitation and appreciate being here. I'm going to really talk a lot about kind of what we don't know about treating operable pancreas cancer. I think everybody, on the call is familiar with the fact that, at this stage of in the treatment of pancreas cancer, only patients who can have an operation to remove their tumor are able to be cured, obviously, with the use of systemic therapy, typically either preoperatively or postoperatively. But I would argue that as a community, we haven't done a great job in studying very rigorously the best way to take care of these patients. And with the evolution of many technologies now, there are just an ever expanding number of questions about how is the best way to treat these patients. And I just want to raise some of those issues and show some of the recent data in the field. So next slide. So I'll start by just showing a few of the more recently reported trials that have been conducted by the NCTN cooperative groups, because I think there's some instructive lessons here and important data that's come out of them. This is SWOG 1505. This is really the only randomized trial which has directly compared FOLFIRINOX and gem-nab-paclitaxel in resectable pancreas cancer in this study using a perioperative chemotherapy approach. So patients got one of the two regimens preoperatively, had surgery, and then completed adjuvant therapy for a goal of 6 total months of chemotherapy. And what you can see from the curves is that they're quite overlapping and pretty amazing, nearly identical 2-year overall survival in this study. And while we often think about FOLFIRINOX being superior, certainly in the setting of advanced disease, this study did not really bear that out. Unfortunately, neither of the regimens really hit the pre-specified efficacy threshold in this trial, further arguing for the fact that we have a long way to go with respect to improving care. But this is really one of the only sets of data which, tells us that at least in the preoperative setting, it didn't seem to be a big difference between these regimens. Next slide. This is a study performed led by the Alliance, which actually looked at patients specifically with borderline resectable pancreas cancer. So patients with resectable disease, but that had vessel involvement. And the question here was to try to understand whether adding radiotherapy in the form of SBRT would improve or at least be equivalent to the use of FOLFIRINOX and alone without radiotherapy. And this trial, as many of you may know, was stopped early because the arm containing SBRT at the planned interim analysis mandated closure because not enough patients were going to surgery and getting R0 resection. This is a fairly controversial study because when you look at the total systemic therapy that patients are getting in each arm, it's very similar. And so the idea that missing one cycle of FOLFIRINOX could result in an inferior outcome, it's a little bit hard to believe, and it is a fairly small study. So this may have, may have been one of those statistical fluky type of things, but at the end of the day, there certainly was no signal that adding radiotherapy, was a benefit in this population. And I'll allude to this later because there have been other data sets in this population to suggest that as well. Next slide. The most recent, large trial from the United States was just reported at ASCO, this past year. It has not been published yet. This is RTOG 0848. A trial that took about a decade to perform and really was asking the question, in patients who had surgery, received adjuvant chemotherapy and did not progress, is there value in adding adjuvant radiotherapy in that setting? There was initial randomization to patients receiving erlotinib, which many people can't even remember is an approved drug for pancreas cancer, but back then, it had just been approved and there was interest in studying it. The gemcitabine versus erlotinib plus gemcitabine arm, was a negative result, which has been already published. But really the larger question was the radiotherapy question. Next slide. And this is the overall data from all the patients looking at overall survival and disease-free survival. And what you'll see is that in overall survival, there was a numerical increase in survival, but which was not statistically significant in overall survival for the whole group. Whereas for disease-free survival, there was a numeric and statistically significant improvement for the addition of radiotherapy, which is obviously perhaps not that surprising since, radiotherapy is designed to decrease local recurrence. It appears to have had some effect in that regard here. But the really interesting data, next slide, was that when you looked at pre-specified subgroups of node negative and node positive patients, in the node positive patients, there was no difference between the groups in terms of outcome. However, if you were node negative and you received radiotherapy, you had a statistically significant improvement in overall survival, a median overall survival that was actually almost a year longer. And that is, for pancreas cancer trial, that is a really large difference. Now, granted, only about 10 to 12% of the patients on the study were node negative, which is in keeping with what we typically see. But again, this was a pre-specified subgroup. It's not a post hoc analysis. And so this is statistically valid result. And really, I think is a result which certainly our group has considered as potentially practice changing, and certainly for those patients who undergo upfront surgery. So again, this study isn't published yet, but this is is mature data, and will probably have some impact on how we take care of our patients. Next slide. And here I just wanted to show you some of the trials which are in progress. A couple of these have finished and been reported in abstract form, such as Prodigy 48, which was a study looking at the value of FOLFIRINOX versus FOLFOX. Predominantly in this study, not surprisingly, FOLFIRINOX was superior. The PANDA study at the bottom, which was a study examining the value of radiation therapy in borderline resectable patients, similar to the Alliance trial, was recently reported at ESMO and read out as negative. Neither of these have been published. And then the other studies are really looking at, two of the studies, the Alliance 21806 and PreaPanc3 from the Netherlands, are interestingly identical designs, really asking the age-old question, which we have not answered, about is perioperative chemotherapy before and some after, a superior strategy to the traditional surgery first and adjuvant therapy strategy, again, using FOLFIRINOX. It's really nice that we have two large studies conducted in different countries, with the same design, because we should get very high level data to finally address this question, at least in part. Both of those studies are nearing completion of accrual, so we can expect probably mature data, probably in about, I would expect about 2 years, hopefully. And then the PreoPanc2 trial from the Netherlands up there, which has also resulted in some very interesting and provocative data about the value of radiation therapy, and that there seemed to be an equivalent survival in patients who received chemoradiation and gem-based chemotherapy to those who received perioperative FOLFIRINOX, which many of us kind of find hard to really understand. Again, this is a trial which we need a bit more information about. There are other ongoing studies as well, but in the interest of time, I wanted to kind of just point out these, which I think are important and asking important questions in the field. Next slide. So, as I said, I think that, we have not addressed a lot of the really important questions that we all have every day when we treat our patients. One that comes up every day in everyone's clinic, I think, when they're treating patients with operable pancreas cancer is, which regimen should we give them? Again, we only have SWOG 1505 to inform some of that data. And how many cycles should we give them preoperatively? And does it matter? Is there a sweet spot for most patients or not? How do we even best assess treatment response in the preoperative setting? We use CA19-9, we use imaging, which we know is very difficult. Are there better ways to do this? Again, I brought up radiation, both preoperatively and postoperative radiation. The question of the place of radiation, is there one? How should we use it? Still unclear in the field. And for those patients who we do give preoperative therapy to, should we give them postoperative therapy? And if so, how much? Should we change if there's a certain outcome on their pathology, et cetera? Again, questions that are really important and that impact us every day that we don't have, high-level answers, high-level data to address. Next slide. So, when we're talking about the type and duration of preoperative chemotherapy, obviously these days we have modified FOLFIRINOX. We do have NALIRIFOX, as well. And, Gem-Nab-Paclitaxel, I'd say FOLFOX is probably for most patients not an optimal regimen based on the data that I just showed you from the PANDA study. And the question of, 2 months, 4 months, 6 months preoperatively, what's the right number? Still a question in our field. Or should it just be individualized, which is, I think, how most of us currently practice. Next slide. For the assessment of preoperative treatment response, there is a lot of evolving technologies that many of you are obviously quite familiar with. Circulating tumor DNA is being ordered, used in clinical practice, at least those assays are being obtained. Obviously, we know many companies have these assays. And the question is, do they do they tell us something dynamically during treatment, or are they going to be useful at all, or are they only going to be useful for after we've treated the patient, resected them? Are they positive or negative? Are we going to use them in that space? So I think this is evolving. We don't know yet, but it's certainly a question that's of great importance given the improvements in these assays. The metabolic response, groups like the Mayo Group have, reported that metabolic responses assessed by PET scan can be highly prognostic. That really hasn't been validated in any prospective manner, but there's certainly provocative data suggesting that it may have value in helping us decide about whether to continue chemotherapy and even whether to operate on patients based on whether they've had a PET response or not. And then, even more novel and cutting edge is the field of radiomics and using mass calculated by CT scan to assess responses to chemotherapy. This is being pioneered at MD Anderson by Eugene Coy, and there's some certainly interesting data from that group suggesting that radiomics may have a role in helping us understand responses to therapy. Next slide. This is a study that attempted to look at the role of postoperative therapy after patients got induction chemotherapy prior to surgery. And obviously this is a retrospective study, but you can see that for the whole group, there didn't really seem to be a big effect of giving chemotherapy in the postoperative setting if you got preoperative therapy. However, for patients with node positive disease, there did seem to be a benefit to giving adjuvant chemotherapy. This is another important question that we grapple with all the time. Should we give more of the same chemotherapy? Should we change if patients have positive nodes or not much of a pathologic response? Open and very important everyday question for us to address. Next slide. And again, the question that seems to never go away in our field, the role of radiotherapy, and it just seems to be getting more complex because there are more ways to deliver radiation therapy. Now we have SBRT, we have protons, in addition to the more conventional long course and hyperfractionated regimens. Really at the end of the day, I think, what we need here is more science to understand if there are patients who really, which patients really benefit from radiotherapy, because we clearly all have seen patients who've had marked responses, even complete responses, when chemoradiation is administered in the pre-op setting, but it just has been very hard to demonstrate benefit, for patients overall. I think the 0848 data is provocative in that it at least suggests, and it seems to make intuitive sense, that if you have a lower risk of systemic therapy, radiation therapy may be a benefit in this disease, which we know has a high local recurrence rate. Next slide. Some additional gaps to just comment on, obviously, quality of life and patient outcomes, centered outcomes become much more in the forefront of our research, as well as the value of the care we deliver. I think we really have to make sure that we study this in the setting of resectable disease. There are well-documented disparities in care delivery in our country. There's very profound data in the surgical literature about patients in economically underserved areas, how they don't get offered curative therapy as often. And so these are really important areas for us to obviously not forget about it. And obviously, it goes without saying that if we can embed correlative science into our studies whenever possible, hopefully we can get as much out of them as possible and learn to address many of these gaps. Next slide. So, the past has been, surgery, adjuvant therapy. We've obviously moved into the era of more effective chemotherapy and neoadjuvant therapy. I would say, as I said, that we haven't moved fast enough to understand these changes that we've made in our approaches to our patients. But now things are accelerating at an even greater pace. And, I'm sure you're going to hear, in the next talk about the exciting developments in systemic therapy that we're all excited about. But our tools to examine the genome, to examine the transcriptome, and now the tumor microbiome, et cetera, equip us to understand tumors at many different levels in a more profound way. And, it's certainly my hope that we're going to integrate these tools in a more effective way and a more thoughtful way to design our trials so that we can learn more quickly and not spend the amount of time we've spent giving neoadjuvant therapy and not even understanding what its real place is. So hopefully we're going to get smarter. We're going to do smarter trials with more embedded science to move our field forward and obviously help our patients overcome this terrible disease. I think that's my last slide. Oh no, well, we can skip that one, I think. I think we can skip this. This is just an example of some of the other ongoing trials, which are examining some of the molecular questions. But I think in the interest of time, we can move on. Thanks.
Okay, thank you. That was excellent.
Yep.
Unfortunately, when I share, I can't see if anyone has questions. Ashkan, I'm gonna defer to you. Did you see any questions while I was sharing?
No, I had a couple of questions, and that is, I guess, Dr. Lowey, I just wanted to thank you. That was a wonderful presentation. I guess, what are some of the exciting things that you see coming out um, in
Yeah.
that might move the needle based on some of the things that you mentioned? Is there anything exciting
Yeah.
that you're looking?
Well, I mean, I think certainly, at the end of the day, obviously, we need better drugs. And I think we all know that. And that's going to be, I don't want to steal the thunder from the next talk because that's what they're going to talk about. But I would say that the fact that we have a few large trials looking at the role of perioperative therapy, that will really help us kind of, understand if, we should take that platform kind of and use that as the platform to investigate, to add our new drugs to. Because I think part of the problem with the coming of all of these new agents is when we start studying them in the resectable space, how are we going to do it? Are we going to give we're going to do surgery first and give them after? Or are we going to, you're kind of piling question upon question. So I think the fact that we'll get these studies from Alliance and the Netherlands answered about at least the FOLFIRINOX question. Does it matter if you give perioperative or adjuvant therapy? Is one really better? That will really kind of help us set the stage for now adding KRAS, inhibitors to, and how should we do the trial? Because otherwise you have, so many questions about, and it really becomes very cumbersome. So I'm excited about that. Some of these other studies, obviously the vaccine trials are very exciting because of the early, it is very early, but there's some early signals that the patients who are responding to these vaccines are doing very well. That has to be validated. But I really think that in the next, 5 to 10 years, we're going to make incredible progress in this disease, and we're going to see really large jumps in patient survival, both long-term and, and shorter term.
Thank you. Yeah, I don't see any other questions unless anyone else wants to just chime in. Okay. If not, we can move to the next speaker.
Well, thank you, Dr. Hendifar and Dr. Lashkari, and big shoes to fill after Dr. Lowey, who gave a very comprehensive overview of perioperative care in pancreatic cancer. I'm going to try to shift it a little bit to talk about systemic therapy for more advanced disease, and then kind of the bigger strides that are being made for future treatments across all stages, particularly around care delivery. Next slide. So this is just meant to kind of highlight where we've come in terms of a timeline. It's really just points out that, really for the last 3 decades, we've in pancreas cancer, the true FDA approvals have been with drugs that are true cytotoxic chemo, going from single agent to quadruple therapy with FOLFIRINOX. Then came the addition of nab-paclitaxel and gemcitabine. The only real kind of targeted therapy really was with olaparib, and that came back in 2019 for those that have germline BRCA mutations in the maintenance setting for advanced pancreatic cancer. It wasn't actually until February of this year that we were all excited that despite it still being cytotoxic chemotherapy, there was an FDA approval for a new regimen based off the Napoli-3 study for advanced pancreatic cancer as a first-line treatment, which incorporates liposomal irinotecan. Next slide. And, just to highlight, when we talk about how we think about applying treatments for patients in the advanced setting, it really comes down to performance status and toxicities. Oftentimes, those patients that have a poor performance status or the multiple comorbidities, we think about single agent gem, and then you subsequently move to gemcitabine and nab-paclitaxel. We know that the median overall survival for patients getting even Gem-Abraxane is around 8.5 months. Now, with the Napoli-3 study, which it showed in a multi-center international study done in 770 patients, is that there is another regimen which does lead to a comparable response to FOLFIRINOX. It has, albeit a slightly different toxicity profile, where the rates of neuropathy were significantly less compared to Gem-Abraxane, as well as those with hematologic toxicities, but had higher diarrhea and nausea. You give a lower dose of oxaliplatin. So these are things that we weigh as options for patients in the first-line setting. Now, this could also be applied in the subsequent line, but the study for Napoli-3 was done in the first-line setting. But again, our armament really, as of today, is cytotoxic chemotherapy outside of clinical trials. Next slide. And this is really meant to highlight the growing problem with pancreas cancer. A lot of people make the argument that immunotherapy has been a paradigm shift in cancer care and has led to a decrease in mortality rates among many cancers that employ immunotherapy. But pancreatic cancer really is expected to become the second leading cause of cancer-related death by the year 2030. And often, many of us get asked the question, can we apply immunotherapy in pancreatic cancer? Next slide. The issue and the reason why we really, outside of clinical trials, don't employ immunotherapy, whether it's checkpoint inhibitors or vaccine therapy, is really because of the tumor microenvironment. And this is meant to really show that besides the tumor, there are many constituents which are truly immunosuppressive. Next slide. Now, this is an example of what are the elements that really serve as a barrier to employing immunotherapy successfully. And maybe these barriers can be targeted so that we can sensitize this tumor potentially to immunotherapy or checkpoint inhibition. Pancreatic cancer is known to be void generally of good immune infiltrating high quality T cells. We all know that in terms of stromal density and stromal pressures across all tumors, pancreatic cancer sits at number 1 or 2. There's an abundance of immunosuppressive myeloid cells, which again they inhibit from those T cells from getting in, and if those that do get into the tumor microenvironment, they are not active. And then the actual induction of the blocking checkpoints for PD-PDL1. Next slide. So one of the things we've done actually with our group is we wanted to understand exceptional responses. So we've looked at patients that are true 10-year survivors with pancreatic cancer. And we looked at multiple biomarkers, but ones that we're interested in our lab is, focal adhesion kinase, which is a tumor microenvironment master regulator, and CXCR4, which is a protein that's thought to be immunosuppressive. And it's interesting that across the tumor, when we've done multiplex IHC, these immunosuppressive proteins are significantly lower in those patients that have true exceptional responses, and especially in those cell types that are thought to be immunosuppressive, like those that are CD66B positive. Those are thought to be tumor-associated neutrophils. Next slide. So as an example, one way where we think that there may be a potential for synergy with checkpoint inhibition is, can you target one of these tumor microenvironment regulators, such as CXCR4 as an example? And this is an active clinical trial that we have here at Cedars, where we're targeting the immunosuppressive tumor-associated neutrophils and myeloid phenotypes to see, can we synergize with checkpoint inhibitor? And this is really meant to see, can we even combine it with other agents? Next slide. As Dr. Lowey had really highlighted, how do you study the tumor and its biology. One way we've done it is we have neoadjuvant platform studies where we sequentially give chemo followed by the intervention. In this case, it's checkpoint inhibitor with anti-PD-1 antibody and that tumor microenvironment master regulator focal adhesion kinase. The way we've thought of it here is that by isolating the intervention and getting biopsies before and using the surgical specimen, we get to understand really the biology of the tumor so that we can help not only answer current questions, but allow us to really understand the mechanisms of resistance, whether it's for immune targeting drugs or whether it's for specific targeting of KRAS, for example, which we'll talk about. This study is almost nearly complete and will also help us answer, is there an impact on pathologic complete response correlated to immune response? Next slide. Now, the other part that I really wanted to focus on, and I know this was highlighted by Dr. Lowey too, is, are there ways that especially patients who are supposed to get curative intent surgery or access to trials, if they come from underprivileged backgrounds or lower socioeconomic status, it's actually been shown there's a vast difference in it. Now, in general, as many of us know in the community, from the time of a suspicion of a diagnosis to actually receiving the diagnosis and commencing treatment, it on average can take up to 4 to 6 weeks. So a model that we've employed here at Cedars, next slide, really focuses on a patient-centric model where patients come in and on a single day, within a half a day, they get a same-day scan. Then they have a full history and physical. They see all the disciplines. They're scanned, their entire history and physical is reviewed. A plan is assessed that day. We assess them for a clinical trial, and they get access to ancillary services. This is done at other large academic centers in different iterations. And we integrate doing germline testing, getting the NGS already done, which is also very important, or ordering that, and then coming up with a treatment plan that could be executed even at their local site, whether they come from other communities. And by doing this, normally what takes 4 to 6 weeks, we actually shorten that down to half a day. Next slide. And this really just is meant to show an example of how a patient progresses through their day with the pre-evaluation, getting their history and physical. This is actually taken from our actual clinic. And the patients, the way it's designed is that they're going to see each discipline: surgery, radiation oncology, medical oncology, GI and palliative care. And then there are also the ancillary services, which are quite important. Oftentimes, many of us see patients that are not on enzyme replacement therapy. They haven't seen supportive care medicine, dietitian involvement. It happens much later in their course, but if this happens earlier on, it's quite critical. And the other part, which is really important, not only for research, is actually access and evaluation for clinical trials. As Dr. Lowey mentioned, answering those perioperative questions is critical. But oftentimes, patients will come for second opinion, but that they've already missed the window to enter one of those critical perioperative studies. But if they're assessed at the time of diagnosis, these are options for them. So again, this just comes to show that a multidisciplinary evaluation can have a big impact on patients' care. Next slide. So we actually went ahead and we aggregated the data from the patients we've treated since October of 2022. We've treated now close to 300 patients, but within the first 100 that we already had mature data, we looked at the rate of changing disease management, staging, tumor resectability, clinical trial enrollment, and ancillary service involvement. And we compared it to our own institution's historical metrics before the implementation of the multidisciplinary same-day clinic. What's interesting is that patients that come to PMDC versus those that don't, the resectability status, actually those that came to the clinic changed in about the 13.8% of the time. The clinical trial enrollment rate, which is actually a very important metric, was threefold higher. So 1 out of every 3 patients actually that came to the clinic enrolled in a clinical trial. A lot of these were perioperative studies. And even if those that were found to be metastatic, again, they were assessed for those trials at that same time. So it's really a time-efficient care model that can have a significant potential impact on patients' clinical course. Next slide. The other part of, I think, of comprehensive care, as many here know, is really next-generation sequencing and understanding the genomic landscape of pancreatic cancer. We all know that 90% of this tumor is KRAS mutated, the other common mutations being TP53, CDKN2A, and SMAD4. These are the core driver mutations. And then there's that unique subset of the wild type pancreatic cancer, it's KRAS wild type. And that's important because they often have different drivers that can be potentially targeted. And it's routinely now expected that patients across all stages of the disease should undergo next generation sequencing, not only for determining treatment responses, but often this sequencing is critical to the assay that Dr. Lowey mentioned for ctDNA. You have to know the sequence in order to be able to monitor for disease, minimal residual disease, or disease reoccurrence. Next slide. Now, this work done by one of our colleagues, Dr. Pishvanian, actually just highlighted the importance of when you do sequencing and you match patients with pancreatic cancer, that it actually really can have an impact. Now, I want to highlight, this was done in 2020. Now, in the last 2 years, as the subsequent slides will show, we are very excited about a very specific molecular target. Now, in 2020, those that had matched therapy, their median OS was 2.5 years compared to the unmatched patients that were 1.5 years versus those that had no match, which did even worse. And again, this were in patients that had advanced disease. Next slide. So this brings to, I think, one of the things we're very excited about right now, which is KRAS targeting. Now, KRAS, we know that is a driver in 90% of pancreatic ductal adenocarcinoma. We also know that it's really been the holy grail, not only in this disease, but in other diseases, which KRAS is quite important. But this has been very, very hard to target up until probably recently, based on a lot of preliminary data that's been presented regarding KRAS targeting. Next slide. So now there are many companies looking at targeting KRAS via multiple mechanisms. One which I wanted to highlight here is a drug called RMC-6236. This is a very specific tri-complex RAT-on inhibitor, which means it actually targets both the tumor and the protein, the KRAS protein, both in the on and off state. And as an example, this was done in a phase 1 setting in patients that were heavily pretreated. And this waterfall plot is actually quite impressive when you look at it. This is across all doses in the phase 1 study. You can see that the change in tumor responses based off those patients that had KRAS G12 mutations is quite remarkable. Even in the past, though this is still a phase 1 study, this is the depth of those response curves is quite great. Next slide. Now, this data was probably just shown by the company that is working on this drug probably about a week and a half ago. This is the updated data from their phase 1 study looking at the pan-KRAS inhibitor, which is 6236. And you can see even within the phase 1 study, the median PFS in heavily pretreated patients is looking at 8.5 months. And the median OS in terms of this analysis was then at 14.5 months. Now, these drugs, and again, we, for the purposes of this talk and time constraints, are generally very well tolerated. The biggest side effects are really rash and GI upset, nowhere near the effects that patients see with common cytotoxic chemotherapy like FOLFIRINOX and gemabraxane. And this really does present not only an important target that a lot of people are working on, but it really provides, I think, the future next step of looking at combining KRAS targeting with even other drugs that, whether it's chemotherapy or immunotherapy. Next slide. So the future really is a study that many of us in the pancreatic cancer community are quite excited about, which is RASolute 302. This study is designed for patients that have metastatic pancreatic cancer that have progressed through one line of therapy with a good performance status, where very appropriately they will either be randomized 1-to-1 to getting standard of care chemotherapy in alteration of what they received in the first line. So if they had FOLFIRINOX, they may get gemabraxane in the second line, or if they got gemabraxane, FOLFIRINOX, or NALIRIFOX for that matter, and or to get RMC-6236, which again is a pan-KRAS inhibitor. At the same time, I should also mention that it's not only this pan-KRAS inhibitor, but not only this company, but multiple companies are looking at specific isoforms, whether it's KRAS G12D or the other KRAS isoforms for specific targeting of those KRAS mutations. So again, this is something that we're all, I think, quite excited about. It represents, I think, the next step for treatment for pancreatic cancer. I think that should be my last slide, and I'll hand it over to Dr. Hendifar.
All right, that was very nice. Any questions for Dr. O?
That was fantastic. Fantastic talk. So, the just so to reiterate, the Revolution Medicine drug that's in phase 1 currently. Is that going to be going into potentially phase 3? Do we need a phase 2 on that?
Thank you.
I can't
I
hear
was
you.
muted. I think because of the magnitude of how great the data
Yeah.
is, they are moving forward with a larger study. Again, I mean, Dr. Hendifar and Dr. Lowey have more experience. I think it's been rare to see this type of a response with heavily pretreated patients previously.
Yeah, I mean, you really you have to realize the magnitude of those results. That these are patients who had multiple lines of therapy, advanced disease, and their median survival is longer than the median survival of the patients in the initial, FOLFIRINOX versus gemcitabine first line study. So it's really incredible.
That's crazy.
Yeah, yeah. So
Yeah, and speaking of phase 2 trials, they've really fallen out of favor.
Yeah.
Because financially they're almost as expensive as phase 3 trials, but don't really,
right,
just doesn't pencil out.
get you to approval. So
Right.
so yeah.
All right. So I'm going to quickly go through this, and we have a case at the end that hopefully we'll get to. Go back to share. Talk about something a little bit different. Okay, I mean, in 24, we have all these amazing developments as discussed, and localized pancreas cancer as well as advanced disease with the KRAS inhibitors. But in the field of supportive care or trying to address symptom management in patients with pancreas cancer, we got a few wins ourselves. But first, I mean, let's talk about the serious problem of cancer cachexia and pancreas cancers. At least between 2/3 or up to 80% of patients with pancreas cancer will meet the definition of cancer cachexia at diagnosis. And this is associated with significant mortality and morbidity. People feel awful, they're thin, they are weak, and they die earlier when they lost weight. Now, despite all these issues for cancer cachexia, we really don't have any good interventions. Here are some ASCO-based guidelines. Yes, you can refer the patient to a dietitian. They're almost never happy after their consult. You can occasionally do, artificial nutrition, but that's not really guideline-based care. No vitamins or supplements, exercise, not really good data. And then, you could try Megace, which we've done for decades. You could try olanzapine for nausea. It may or may not work. But other than that, there's not really much we can do. In pancreas cancer, the weight loss or cachexia is so pronounced that we've tried to make it kind of organize the approach to it. I don't know why this keeps going forward by itself. So weird. Any event, we've divided weight loss in pancreas cancer to conceptualize into 3 different categories. One of them is anorexia. Of course, that's, patients report they're have zero appetite, the cancer is bad, the chemotherapy makes it worse. Second category is malabsorption. Now, that's something that we can actually treat. We can prescribe patients pancreatic enzymes when they have a tumor, whether it's localized or advanced. Very often patients have exocrine pancreatic insufficiency, and that should be recognized. And the last category are patients who, they may have a little bit of anorexia, but they have a little bit of malabsorption, but we literally see them wasting in front of our eyes, and that's described as cachexia. And our current understanding of cachexia has been that it's an inflammatory response to the tumor, and the only effective way to address it is to actually treat the cancer. Now, there is a pathway, GDF15 G4all, that hasn't made a lot of noise in medicine. It's secreted by macrophages and endothelial cells. We know it regulates feeding and immune function, and it's been associated with hyperemesis gravidum. So women who develop hyperemesis gravidum, really high circulating levels of GDF-15. And recently, it's been looked at in pancreas cancer patients. We looked at a large cohort of these patients, and almost all of them have elevated GDF-15 levels. And this led to a clinical trial. And this was a phase 1 trial that was put together by Pfizer for a GDF-15 inhibitor for cancer cachexia. And despite my recommendation not to look at different cancers and not to include patients from everywhere and not to include them at any point in their disease course, I mean, that's kind of what Pfizer did. This is an international study. It included patients with lung cancer, pancreas cancer, or colon cancer. To qualify for ponsegromab, all you needed was weight loss of 5% within 6 months, which is our definition of cancer cachexia. The patients had to have a high GDF-15. 90% of the patients had high GDF-15s. And you could be ECOG 3. That was okay. You could be ECOG 0, 1, and 2, and you could participate, which is unheard of in a clinical trial. It didn't matter when you got treatment or when you were getting treatment, all those things, as long as you had active stage 4 cancer, even if you weren't getting active treatment, you would qualify. And the medication is given in monthly sub-Q injections, and it was either given a 400 milligram dose, 200 milligram dose, 100 milligram dose, or a placebo. And there are other endpoints as well. So this was recently presented at the ESMO conference. And, you know, patients, as they are in these types of trials, even though this is like a phase 1B, phase 2 trial, patients are always appropriately placed in different dosing groups. It's not really an issue. But what was really remarkable about the trial is that we appeared to see a dose-dependent increase in weight in patients. So the higher the dose of ponsegromab, the greater increase in weight that we saw. And this was the on-treatment group, the per protocol analysis. And what was really even more remarkable is that this was also associated with significant improvements in the FACIT cachexia scale and the FACIT anorexia and the physical activity, all the things that we've had so much trouble doing in cachexia trials, which is actually connecting the intervention with an actual quality of life improvement as well. So, 24, it's been a hard, Dr. Lowey's been at it longer than all of us than here, but I've been at it for quite some time. It's finally time for new therapies and new approaches for pancreas cancer. And of course, we're all very excited about what's to come going forward. So I am going to set up the last bit of the presentation today, which is a case.
Can I just ask you real quickly about the ponsegromab? Thank you. That was excellent. Were there any side effects that were thought to be concerning?
No. I know it sounds crazy. There are no side effects.
Did it correlate with patients feeling better?
Yeah, they did. They really did. Now, the study wasn't really designed for all these. I mean, they did a whole bunch of instruments and they looked at activity. So they're going to probably focus on where they saw the initial improvements for registration, and they're probably going to have to work on what that might look like. But there was lots of, promising improvements in quality of life that they could use in addition to the weight gain. I mean, it's always been a problem with cachexia studies is the FDA's stance on weight gain for cancer has always been, so what? Like, if you can get someone to gain weight, why should we care? Then that's coming from the endocrine division, where I guess they see a lot of weight changes from, abnormal pathophysiologic states. You can think of Cushing's, right? Patient who has Cushing's syndrome gains 10, 15 pounds. That's not good weight. So they say if your cancer patient's gaining a bunch of weight, how do we know that's beneficial for them, for the organism? You're going to argue, well, they're so skinny, now they're not, and they're happier, and they're, but that's not enough. So, getting these quality of life instruments aligned
Sure.
with the weight data is important. Yeah.
Yeah.
All right. Let's do it. This is the toughest case I could think of, or I could find. So can you see it? No.
Yeah.
No. All right, you want a presentation mode? All right. So this is a 54-year-old woman. She's a germline BRCA2 mutation. She presented in 2023 with a I would say locally advanced, with an advanced pancreas ductal adenocarcinoma. She had an elevated elevated total bilirubin, and she required decompression and stem placement. She had a CA19-9 of about 2,000, and she had a solitary liver lesion. Try to get the slide on this. There it goes. All right. So she was enrolled on a study with FOLFIRINOX and a investigational agent. Dr. O, I think you know this
Yeah, I
patient.
know her very well, yes.
You want to take it from here?
So she actually went before we even had her mutational profile and the germline testing. She went on this trial with a drug called ABTL0812. It's a drug that actually binds and activates the nuclear receptors of PPAR, and it leads to a blockade of activation in the mTOR pathway. When you do that, it actually strongly induces autophagy. So that's the mechanism of action. We think, and it was randomized to that or placebo, but she developed some toxicity, so we thought she may have actually had the real drug, but had a great response. But then we found out she also had a germline BRCA mutation, and she started her disease course. She had a FDG-avid solitary liver lesion that subsequently really disappeared. Her tumor markers normalized, and she's one of the patients we thought of down an oligometastatic treatment paradigm. This is her MGS profile. It does confirm that. You can see she's KRAS mutated, but has a high VAF with BRCA2, indicating that it's likely that she has a germline mutation. This was further confirmed on germline testing.
So Dr. Lowey, we get to get a free consult right now.
Yeah. So Dr. Lowey, what happened, and we can even pull that image, is, we talked to her about many options. Olaparib is an option in the maintenance setting, because she finished 12 cycles of FOLFIRINOX. She did develop toxicity to that. So we said you could do maintenance FOLFIRI, you can do PARP inhibition, or the kind of rare situation and somewhat a remarkable response to systemic chemo plus radiation is to think about doing surgery potentially for oligometastatic disease. And that's kind of where we are.
So the liver lesion was still visible, or it was no longer visible?
No longer visible.
No longer visible. So really it was just to resect the primary, examine the liver, and see if you could find anything. And
exactly.
Yeah.
And we utilized the SBRT was both to actually improve the tumor response locally, but also as a bridge to test the biology during that time with the liver have come. But in that 8 weeks, there was no evidence in the subsequent scan of the liver.
And so what was her pathology at resection?
We're not quite there yet. So she's she posed the question to us: what if I don't do anything?
Right.
Versus should I do the surgery, or should I just go on a PARP inhibitor now? Yeah. She's still debating and has posed the question to us.
Yeah. Well, I have a couple of these people, and they're very rare, but there are some folks who I have two men that I can think of. One who had a biopsy proven liver metastasis, got chemo, had no remarkable genetics, got chemo, liver met, disappeared, and his primary shrunk to almost nothing. I resected him. He had a complete response in the primary, and we could never find his liver met, and he's 4 years out, free of disease. I have another guy who had a very bulky distal cancer with a liver metastasis, who was being treated at Scripps and got chemotherapy, had a pretty nice response in the primary, and they did SBRT to his liver and then continued him on chemo. And he kept asking them, will you operate on me? Will you operate on me? And no one would operate on him except crazy me. So he came to see me, and I resected him. His tumor was invading the greater curvature of his stomach. We did a distal subtotal pancreatectomy, splenectomy, and partial gastrectomy. And then we also resected, they had put a fiducial in the liver, and we resected the area of the fiducial in the liver. The liver was complete response, nothing left, but he did have disease in his pancreas that was left over. But all of his margins were negative, and he's now, I want to say, about 3.5 years free of disease. So there are these rare people, but I think, we would have done exactly what you guys did, which is string it out as long as possible. And, and I think using radiotherapy in those circumstances is very reasonable. And, yeah, I mean, you're not gonna cure most of these people, but I do think in the right patient, it's reasonable. And one of the things I asked the RevMed folks was whether they were seeing differential responses in the primary and the metastasis. And it's too early to say, but they did say that it seems like the primaries responds more slowly and not quite as well, which kind of almost, furthers the argument for, an aggressive local therapy if you have really effective systemic therapy. So it's another one of those situations that we've seen in oncology, where I think as the systemic drugs continue to get better, we're going to do more pancreatic surgery, not less.
Yeah, that's very, very insightful. Thank you for that, Dr. And she is young, so she's 50 years old, so we are leaning towards doing surgery as long as.
Yeah, obviously it's always about whether you think the morbidity of the surgery is going to be very acceptable, because you're in unclear territory as to the benefit. Yeah.
How's the marker doing currently?
Still normal.
It's normal. That's
Great.
pretty.
Yes.
That's pretty convincing.
Yeah.
Can I ask a quick question? Do you guys use CTCL or plasma-free, like MRD testing in your patients, or not routinely?
At our institution, Greg Botta, our medical oncologist, has been really a leader in this area, and has been, definitely uses it, particularly in kind of difficult decision-making, areas where you're trying to determine, like the person who gets neoadjuvant chemotherapy has a really good response, has a complete resection, but already has neuropathy, doesn't want more chemo. Yeah, he'll get circulating tumor DNA. And if it's negative, then talk to them about, considering not giving more therapy. Whereas if it's positive, it kind of gives you another, you pretty much know that person's going to recur. So situations like that, where clinical decision-making can be very vague, we still have a lot to learn about it, but I think it's pretty clear from the data that if you have a resection and you have your ctDNA positive afterwards, you're going to recur, and pretty quickly.
Yeah, I agree.
Yeah.
We use it sometimes, like if we have a perioperative patient that we can't really sort out how they're doing.
Yeah.
If the tumor
response
marker
assessment.
doesn't work, and
Right.
Yeah.
So
they're definitely niche,
yes,
opportunities or circumstances to use it. But I don't think, we're already like colon cancer, where,
right. Right.
after surgery, really know.
Agree.
Yeah. But it's,
Plus,
I'm sure
especially
Greg is
localized.
leading the way. He's going to figure it out soon.
Yeah,
Exactly.
yeah, we hope so.
Yeah, he's done a lot.
All right. Any other questions from the audience at this
I
time?
was curious, at the MOASC Cancer Center, do you routinely use radiation in borderline resectable?
We do if it's arterial involvement, not if it's
Ah.
purely venous.
And if it's purely venous, do you go and just reconstruct the vein, or do you just kind of?
Yeah, we resect it and reconstruct it. Yes.
Oh,
One of those tomorrow.
thank you. Thanks for
Yep.
that's wanted to know.
Yeah.
Yeah, well, thanks everyone. It was a great hour. It went by so
Yeah.
fast.
Yeah.
Thanks for attending on election day.
Yeah.
Uh,
Thanks
But
for
you're right, it was a
joining us.
nice break from all that.
Yes. Good night.
Thank you, everyone. This
Thank
was
you.
wonderful. Thank
Bye.
you, Dr. Lowey, Dr.
Sure.
Osipov, Dr. Hendifar. Thank you, everyone, for joining us. And you guys did a fantastic presentation. I think we all learned a lot.
Thank you.
Good night.